Hi, everybody. Welcome to this first COGA meeting. I would like to thank Dr. Lanju for this kind invitation. So the task of this lecture will be to give you an idea of what is the treatment of uterine malformation with the shaver technique. So let me first share the screen. So the title of my presentation will be the shaver treatment of the uterine malformation. So at present, I'm based at Renji Hospital in Shanghai since April 2019. So as you know, I've been introducing in operative hysteroscopy the shaver technique. The first shaver operation was done in 2009, and it was with the 24 French shaver. At present also, in Shanghai, we have the 24 French shaver because we cannot use the 19 French yet. The 19 French has not been approved. But anyway, the shaver device is the same. It's only the optical part which is different. But anyway, we should now speak about the 19 French shaver. You see the shaver is made by two parts. This is the optical part, and this is the shaver, actually the shaver device. The optical part has been changed. So we go from 24, which is 8 millimeter, to 6.3. The shaver is the same. So the shaver size is about 4 millimeter, and this is made by two parts, one handle and one blade. There are two types of blade. One is better for polyps, the other one it's better for myoma. One has a fluid beak shape, which is good for myomas, and the other one, which resembles the jaws of the shark, which is very good for polyps and intracavitary pathology. So the only thing you have to do is to clip in the blade inside the handle. Each blade is made by two tubes, an outer tube, which has a window at the tip, and the inner tube, which is a double window blade. So you get a suction from here, and you can activate the pedal. The first pedal will activate the suction, so the pathology will go inside the blade, and the second switch will activate the oscillating movement of the blade, and the pathology will be removed. So this is the difference. This is the 24 French shaver. You see this part here is where the cutting device will be inserted. You get two channels for inflow and two channels for outflow. And this is the 19 French, so we go from 8 millimeter to 6.3 millimeter. You see that the difference is that in this case, you have an outer sheet in which you can put the obturator, and then you remove the obturator, and then you put the optical part inside. In this case, the obturator is placed together with the optical system. So you just go in by vaginoscopy with this system, you remove the obturator, and in this part you will insert the shaver. So you see, as you insert the shaver, you will have an elliptical shape of the shaver, which allows you to enter to the cavity in a much, I mean, if you go out, you can enter into the cavity in a much easy way. I mean, the shape of this optical system has been specifically designed for the shaver, while this one actually is a nephroscope. So it's something we had to adapt to the shaver. As you see, this is the overall number of our procedure made with the shaver since 2009 until 2020. The majority of cases are polyps, benign pathology, 81%. Then you get 13% of myomectomy, and you have, of course, 6% of other indication. Of these other indication, because our center is not a center specifically dedicated to infertility, you see the number, the overall number of procedure made for uterine malformation with the shaver, it's only 1% approximately, which is a very slow, very little number, which I'm sure it will increase. This is just to give you an idea of the activity of our center. This is just a 4 months report since we opened the center in August. So we did about 1,489 procedures. Of these, 828 were trophy scope procedures. So procedure made without any form of anesthesia. Mainly some of these were office procedures, so we could do some small operations like small polyps and small adhesions with just with the trophoscope without any form of anesthesia, and in the overall number of IBS procedures is 660. Uh, but what is interesting is that we only did one procedure with the conventional receptoscope. And this single procedure was actually on adenomyosis, not on polyps or myomas. So this is just to show you the trend of, since we opened the center, you see that we had a very big initial beginning, and then slowly there has been an increase in the diagnostic, which is the blue, and in the operative per month. You see that the more diagnostic you do, of course, the more operative, because you get more cases for operative. But this is very important. We moved from just all kind of hysteroscopy made with anesthesia between office procedure and operative procedure. Together with Rudy Campo, since we opened the center, I mean, before opening the center, we have been writing our guidelines, which is a picture of the center in Shanghai. And this center actually has the same concept of digital hysteroscopic clinic as Rudy Campo in Leuven, Belgium, and Ursula Catena in Rome. So there are three centers which share the same experience and almost the same guidelines. There are some difference in China because in China you have to deal with numbers. So the organization also of the center has to take into account also the number of procedures. So according to our guidelines, how can we define uterine malformation? The definition is that congenital malformations of the female genital tract are defined as deviations from the normal anatomy resulting from embryological maldevelopment of the Mullerian ducts, actually. The prevalence is 4.47 to 4 to 7% in the general population. And of course, in the infertility center, you have an increase in the incidence. It goes up to 13.2%. The etiology of this uterine malformation is still unknown. There are several ideas regarding this, genetic alteration, hereditary factors, and also some exogenous knocks to the exposure to some exogenous knocks. The diagnosis, the pre-hysteroscopic diagnosis is mainly made by two procedures. One is the 3D vaginal ultrasound, which can be combined with MRI, so magnetic resonance imaging. Of course, there are several other pre-hysteroscopic tools, like just the pelvic examination. We give you the suspicious of a malformation, and also hysterosalpingography and sonohysterography that can add some information to your diagnosis, especially with sonohysterography. You can define better the vascular aspect of your malformation. The classification, which has been recently, let's say, redesigned, and the one that we normally use is the classification which has been proposed by the ESHRE and SJ conjunction together. So the European Society of Gynecological Endoscopy and the European Society of Human Reproduction. This group of physicians, which were ruled by Grigori Grimbisis from Greece, they came out with this classification, which has a big advantage. You see, it gives the initial U for uterus, C for cervix, and V for vagina. The aim of this classification is that by giving a very small word, a very small indication for the kind of malformation, you get immediately to know which malformation you are dealing in. I mean, if you have a U, you know we are talking about uterus, C about cervix, V about vagina. And also the big new things about this classification is that the normal uterus has been defined, and also it has been introduced the class U1, which is dysmorphic uterus, which was not mentioned in the previous classification. I will speak mainly about these four classes and leave U5 and U6 because this is something very, very peculiar and quite rare to find. Let me define class U0. So normal uterus. How can we define a normal uterus? It's any uterus having either a straight or curved interosteal line, this one, with an indentation not exceeding 50% of the uterine wall thickness. So this line, this indentation should be not more than 50% of the whole uterine thickness. Actually, this can be, this resemble the martini glass shape. You see, it's like a martini glass shape, and this is very important because basing on this definition, you can build up all the classification. What is interesting, and you have to remember when you do an hysteroscopy, if you see from, let's say, the isthmical part, the tubal ostia, you know that this cavity is a normal cavity. If you cannot see, the tubal ostia, it means that this part has been partially obliterated by the uterine wall, and means that you are in this class, which is the dysmorphic uterus, which can be classified as T-shaped uterus and infantilis uterus. U1A is T-shaped, U1B is infantilis. Which is the difference between these two? Well, this is clear that you have a T-shaped uterus, but the difference is the correlation that you have between corpus and cervix of the uterus. In this case, two-thirds of the image is of the 3D image is given by the corpus and just 1/3 by the cervix. In this case, when you have an infantilis uterus, is the opposite. The corpus is a little part and the cervix is the majority, is 2/3 of cervix. You can see clearly that this is a T-shaped uterus. In this case, where you get a very long cavity with a very long cervix, with a very, very thick wall by the side, you are in case of an infantilis uterus. As you see, you can imagine if you are in this position with a scope, you cannot see the tubal ostia. And also here, if you are in this position, you cannot see the tubal ostia. So the idea of correcting dysmorphic uterus in order to increase the fertility rate in case of IVF, or also spontaneous fertility rate, is to cut this part of the wall in order to go back to this image. So also in this case, we should be able to cut this part. Then we go to class U2. Class U2 is the class we normally face in our activity. The majority of uterine malformation actually are septate uterus. They can be partial or total, according to U2A is a partial, U2B is total, which is the difference is that the fundal area is regular, so there is no indentation in the fundus. You get an indentation inside the cavity, which is exceeding the 50% of the thickness of the uterine wall. So you get the first, and the difference is that if it's a partial septate uterus, it stays below the level of the internal cervical os. If it's below, it's a partial septate uterus. If this, let's say, indentation reaches the level of the internal cervical os, then you get a U2B, which is a complete septate uterus. The case I will show you today is a case of U2B treated with the combination of the shaver and scissor. Then we go to class U3, which is a bicorporeal uterus, which can be partial, complete, or bicorporeal and septate, which is the difference. The fundus is not anymore regular. You get an indentation, and if the indentation reaches is below the level of the cervix, you get class U3A. If it reaches the level of the cervix, is U3B, and then if you get class U3C, if it's a combination of bicorporeal and septate uterus. So this is the more frequent cases of uterine malformation. Then we go to class U4, or hemiuterus. In this case, you just get a normal uterus on one side. On the other side, you normally have a communicating or non-communicating contralateral horn, which can be in class U4A functional, and in class U4B is non-functional. So the difference between the two classes of this Robert's uterus, it depends on the functionality of the, let's say, the residual hemi-uterus. So which is the strategy? So according to our guidelines, we always put the, let's say, one pathological indication like polymyoma or uterine malformation. We made a description of the pathology, and we give some hysteroscopic images, and then we go to the strategy. So the diagnosis, as I said before, is mainly due by MRI or 3D transvaginal ultrasound, which is at the moment let's say the more advanced diagnostic tool we have, because it's easy to use, and it giving you immediately the idea of the uterine malformation. Then we confirm the 3D diagnosis by using diagnostic hysteroscopy, mainly with the trophyscope, which is the big advantage of a small diameter, is only 2.9 millimeter. And then we have several operative hysteroscopy options. You can use either the trophyscope and the 5 French scissors. This can be done mainly always under conscious sedation or anesthesia. Then you can use the both kind of shaver, 24 or the 19, because of course the patients are under anesthesia. And of course we should prefer the 19 French shaver, of course, today, because it's much smaller. So also the dilatation is less. You get only, you must dilate until 6.5, no? Or 8.5 or 8. 8.5 with the obturator, which is nothing compared to the 26 receptoscope. Then you can use the 15, the 22, the 26 bipolar receptoscope. Actually, at the moment, the 15 French should be preferred because it's very small. It's only 5 millimeter. Then what we always do routinely, we put the gel by Origin. We put the matter agent gel, which stays inside the cavity and prevent adhesion formation and reformation of the septum. So the follow-up, we normally look at these patients after 3 months. We use the trophyscope in an office setting, of course, and we use the 5 French scissors in case of reformations of the septum, if there is a reformations, and then we apply again the gel. This is our strategy in case uterine malformation. You get 2 different ways of approaching, and I mean the most modern way to approach septum. One is the use of the scissors in combination with the shaver. Why the shaver is good? Because with the scissor you just cut the septum. With the shaver you can remove the upper and lower part of the septum, so you reduce the recurrence rate of this pathology. On the other hand, you can use the 15 French receptoscope, which is really excellent. It's very good because you use electricity, so if you have a bleeding, you can immediately do some coagulation. But of course, there is a big difference between just mechanical and, let's say, electrosurgery. Perforation with mechanical is always less harmless for the patients. Perforation with electricity is always dangerous. But you always have to check by laparoscopy if you do it, because you don't know what you did. If with the mechanical perforation, if you are sure that you are inside the cavity, also you can just wait and see what's going on. And I mean, the damage that you can perform with a mechanical device is always less severe compared any damage you do with the use of electrosurgery. So let me show you this case. As I said before, this is a case of a U2B classification, because you see the indentation reaches the level of the cervix. Actually, by using we did laparoscopy in combination, because and this is you can see that we are on the right side of the uterine cavity, and what is beautiful of the shaver technique, you see that there is no actually communication between the two cavity at the entrance, so you cannot actually looks like if there is a septum which actually reaches the external os, but the let's say you just had one external os, so the septum is almost a very complete septum. Here we are on the right side of the cavity, so by using the shaver we clean completely the caducis tuberosa from the endometrium, which makes it very easy to find the entrance to the other cavity. So the shaver is very good because it reduces the endometrium. It makes the cutting, so the mechanical cutting with the scissor much easier. See, we just enlarged the opening of the other cavity, which you could not see from the use both with trophoscope and or even with the shaver. We could not see the entrance to the other cavity because this septum was actually reaching the almost the external os. This is what I want to say. Then, of course, we remove the shaver, we put the scissor in, and we cut the septum with the scissor. When you do these kind of things, you have to remember you have to change the rubber cap, which is on the operative channel of the shaver. If you don't change the rubber cap, you will lose intrauterine pressure. So you see, in this case, we didn't have the proper rubber cap. So I had to go very close to the septum in order to get this tension. But anyway, I increased the intrauterine pressure and I managed to reach the level of the fundus with the scissor. So, of course, with the scissor, you have to reach the same level of the tubular ostia. So you slowly, and we were lucky because we had the laparoscope, so we could see by transillumination our position. And then this part of the septum, the upper part and the lower part, must be removed with a shaver. You can use the bipolar coagulation, and this is very good because remember that this device can also cut with bipolar current. So according to the power you are using, you can also let's say cut a little bit. So after doing coagulation, we use the shaver to remove this part and this part of the septum. And by doing this, you see that's for very long, it was reaching this level. You restore the cavity, and of course you do a good job for the patient. In this case, we get a sort of uterus infantilis. We could have also removed this part and this part a little bit of the lateral walls, but I personally think that it was already a big result to get this, to achieve this volume of the cavity. So we will see. We give the patient the opportunity um, to conceive spontaneously, and then we will decide whether it's necessary to enlarge the cavity or not. So let me speak a little bit about our center in Shanghai. As I told you before, this plant is also, this concept, including the plant, has been made together with my friend Rudy Campo of Leuven, and it shows you our concept of modern hysteroscopic digital clinic. Everything has been standardized, everything has been speed up and organized in order to have the maximum from a small area. So you get two OR, OR1 and OR2. In OR1, we just do the diagnostic, and OR2, the operative. This is the entrance. So the patients can wait here, they come inside, and if they have to do diagnostic hysteroscopy, they change here, they do diagnostic, and they leave. So it's a very, very, very fast workflow for diagnostic. This is the meeting room. This is my office. Patients who have to do an operative hysteroscopy, they come in, they change here, and they go to the one of the 6 beds we have here, 1, 2, 3, 4, 5, and 6. They go into the OR, they do the operation, and they start to go back to their original bed. So if you do the first operation, let's say at 8 o'clock, and you consider 30 minutes for each operation, 8:30, 9, 9:30, 10, 10:30. So after the first operation, 2.5 hours have gone. So the first patient can leave the center, and we can replace with another patient this bed. By doing this, we can do easily 10 procedure in the morning and 10 in the afternoon. This is the changing room for the doctors. But one thing I want to show you, which is very important, is the workflow for the devices. And so when you use an instrument, the instrument is dirty, it goes out from this door, it's clean here. So this is all a dirty corridor. So the equipment, once has been cleaned, it goes into the sterilization room where we have 2 Tristel machine here and 1 conventional sterile here. So we get the equipment clean and ready in 5 minutes by using the Tristel, which is a high disinfectant fluid system. The instrument, which is then clean and put in the box, go to the storage room. These windows are open and they go back to the OR. So the workflow for the equipment is this in the diagnostic and is this in the operative. So by doing this, we keep all the equipment in the center. We don't send anything into the central sterilization of the hospital. So we know exactly all the problem we have with our devices. We control our devices all the time. So how is, which is the Renji hospital workflow? This is a system, which this is an organization workflow, which has been designed according to the number of patients. So they go to the endometrial pathology unit, which is the outpatient clinic. If they suspect something, they send it to the center where we perform diagnostic hysteroscopy. Only patients who have performed diagnostic hysteroscopy can have access to operative hysteroscopy. We do like this because at the moment we want to be sure that patients who access to operative hysteroscopy are doing this because there is a real pathology inside the cavity. They don't do this procedure for nothing. In future, it could be that these two, let's say, steps could be unified, and you just have patients coming for diagnostic hysteroscopy and going to operative hysteroscopy. So you can speed up all this system, but this system has been very good until now, especially with COVID-19. So we need patients to have the COVID-19 test before they perform diagnostic hysteroscopy. So to see them in the outpatient clinic is much better because they can be prepared also with the COVID-19 test. So this is the welcome area, the meeting room, and my office. It's very beautiful. These are the 3 changing rooms for the patients and for the doctors in the middle. This is the recovery room. We have a big desk for the nurses and the anesthesiologists, and we have 6 beds, as I told you before, 1, 2, 3, 4, 5, and a 6th one here. Each box has its own mirror and his own desk in order to make the patients to feel much comfortable as possible. So these are the 2 OR. We have OR1 only for diagnostic hysteroscopy with a lot of possibilities also to broadcast our images. We had 4 cameras, 1 general camera, 1 camera for the hands of the surgeon, 1 camera for the ultrasound, and 1 camera for the endoscopic images, which can be broadcasted into our meeting room or to any other place around the world. And this is the OR2 in which we can perform major operative procedure, in which we can do, of course, anesthesiology. This is the sterilization system. As you see, we get 2 Tristel machines and a conventional sterile, which these 2 machines can give you the equipment in 5 minutes each. So another important thing is why we think that the shaver is good for adhesion. We don't cut actually the septum with the shaver unless this septum is mild, but we prefer to cut the septum with scissor, which is a mechanical way of approaching septum. But what we do with the shaver is that we remove the fibrotic tissue, which normally is left inside the uterus. So by removing this tissue, we cannot prove, but we think that is much better for the recurrence of the uterine malformation. And this goes also in a, it is also something which has been reported by my friend Stefano Bettocchi, who is trying to not only just cut, but to remove the remaining portion of the septum, because he thinks it's made by not by fibrotic tissue, but actually it contains some cells of leiomyoma. So it's a sort of a combination with myoma and septum together. So he thinks that if he removes, and he does with a loop, this remaining portion of the septum, you get less recurrence rate of septum. Anyway, why the shaver is good? The shaver, anyway, in operative hysteroscopy is good because it minimizes trauma. So one way to reduce the number of adhesions at hysteroscopy is to avoid DNC curettage, repeated DNC curettage, which in China is a big problem. And you should prefer always to have medical management of miscarriages, but anyway, in this case, you increase the number of placenta remnants that you get into the uterus. So it's also true that on the other hand, you get some other pathology. But what is interesting about the shaver technique, both in the treatment of placenta remnants and uterine malformation, is that you reduce the thermal damage. So anytime you have a thermal damage, which is offered by the resection, you leave some permanent ischemic stimulants inside the uterine cavity, and this impairs the fibrinolytic system, and this leaves fibrin inside the cavity, and fibrin inside the uterine cavity acts like a glue and seal the two uterine wall together. So the other possibility is to increase endometrial regeneration. And how can you do this? So you can increase the healing of normal endometrium by keeping the walls separate and by putting something which could, any drug which could help and speed up neoangiogenesis in the traumatized area, and also increase the fibroblast differentiation in order to recreate the normal tissue. So we think that with the shaver and with the application of gel, with the shaver we minimize trauma, and with gel we can have this increase in endometrial regeneration. The gel we are using, it's a Chinese gel. You can keep the walls separate with the IUD, a balloon catheter, and put the gel together. But also you can just apply gel, which I think is much better than using IUD, especially your IUD. In China, we should never use anymore this metal IUD or this ring IUD you are placing inside the uterus, because they are very, they create a lot of problems, and also they recreate adhesions, especially when you cut and leave the IUD. And balloon catheter also is another option, but I personally think that this gel, we didn't have anything like this before. Since I was in Europe, since I came in China, I started using this gel. It's very good because it stays inside the uterine cavity for 14 days. So it has a very high viscosity and very slow degradation. So it stays, it keeps the walls separate, and it modulates the inflammatory response and facilitating scar-free tissue repair by, as I say to you, increases neoangiogenesis and fibroblast differentiation. So I hope I was able to give you an overview of uterine malformations, and especially to convince you that the mechanical way of approaching septum is probably better than electrosurgery. I always say thanks to my friend Rudy Campo of Leuven, my friend Yves Van Belle, whose genius will stay forever in the world of hysteroscopy, and all members of the Rollerball team. So once again, thanks very much to Dr. Lan Zhu for this kind invitation, and I hope you have a very nice Koga forum. Thank you very much for your attention.